So it's going to be about myeloproliferative neoplasm or myeloproliferative syndrome. I still use the term because it's sort of a nice counterpart to myelodysplastic syndrome. So first I'm going to draw a vertebra over here. And I'm going to try to place some things over here, but I know they won't fit because there are many things to mention over here. So last time we did myelodysplastic syndrome, so the problem was in a class 2 mutations. Okay, so basically in myelodysplastic syndromes, the main thing is that there are many cells that are dysplastic, but there are not so many cells. This is a counterpart to it in a way, because over here now it's about class 1 mutations. So class 1 mutations, so these mutations, they're about a increased proliferation. So basically, and it's about the stem cell. So in case of myelodysplastic syndromes or these syndromes we're going to talk about now, and I can say already, it's about older term is myeloproliferative syndromes. Then there were myeloproliferative disorders as a term that was used. And nowadays, the newest term that we use is myeloproliferative neoplasms. Okay. And basically, the way we see it is that the mutation, again, it's a critical mutation which happens really either in the stem cell itself, so like in the first cell in the line, or very near the stem cell. So it's very high in the root of the division. So it's one of the first cells. And the reason why we think about it like this is that also it's the same as with myelodysplastic syndromes. In both of these cases, in myelodysplastic syndromes or in myeloproliferative syndromes or neoplasms, in both cases, if the disease goes on, then we can say a transformation. And because we can see a transformation into a lymphoid neoplasm, so we can see also in 1/3 of the diseases, of course in 2/3, typically they transform into acute myeloid leukemia, but also in 1/3 they transform into acute lymphoblastic leukemia. So in this case, that's why we think that the mutation, the driver mutations, is in the stem cell very likely, okay? But the class 1 mutation, so what is it? It's about high proliferation. So there is a really high proliferation of the cells, but because these mutations that drives the multiplication of the cell, but the maturation goes pretty well, okay? So we don't see too many dysplastic cells over there. So also the function of the cells that are produced is good, okay? So, and now it depends. There are 4 basic diseases that we put under the myeloproliferative neoplasms or syndromes, and we're going to talk about these. But the main thing is the mutation, the crucial mutations, and as I said last time, the stem cells, as we get older, gets many mutations, but if it gets this driver mutation, and typically in this case, very likely it's something with tyrosine kinase. So there's an increased activity of protein tyrosine kinase. And this is why it drives the division faster. There are more cells produced, but they mature well. Okay, so the maturation is okay. Basically, the result is if you do a bone marrow biopsy, I'm going to change the color over here. So if you do a bone marrow biopsy, what you will get is more than 2% of blasts, but also less than 20%. So basically, you will get more than 2% of the blasts, myeloblasts mainly, but less than 20%. So it's not fulfilling the definition of leukemia, and that's why we call it myeloproliferative neoplasm, okay? So there are more cells, and that's what we see in the blood smear. We see more of the cells which are mature. And now it depends what dominates over there. We're talking about myeloid lineage, so it depends if it's erythrocyte or if it's thrombocyte, or if these are neutrophils or leukocytes in general, okay? And then also if all the lineages are decreased, which would be the last one. So, but what are the mutations? So you know these mutations pretty well, of course. But first, what I should mention over here is the BCR-ABL. So BCR-ABL mutations, that's one of them. And it's going to be today about BCR-ABL. I will mention more of them, but it could be FLT3. It could be Janus kinase 2. And that's the one we're going to talk about, these two mainly today, of course, not about it could be KIT. And it could be NRAS/KRAS. Okay. But today it's mainly about BCR-ABL and Janus kinase 2. And what is BCR-ABL? Of course, is the Philadelphia chromosome. So it's the 922 translocation. So, and now we're going to get the 4 entities which belong under the myeloproliferative neoplasms or syndromes. And it's the chronic myeloid leukemia, watch out. It's myeloproliferative neoplasm, so CML. Then it's polycythemia vera, it's the true polycythemia. It's essential thrombocytosis or thrombocythemia, and myelofibrosis. So these are the 4 entities we should remember. And basically, the idea is that CML, I mean, the cells from the myeloblast that will come are dominating. So those are neutrophils and basophils and whatever. Okay, so leukocytes are much higher than the other ones. In polycythemia vera, those are erythrocytes. In essential thrombocytosis, those are thrombocytes. And in myelofibrosis, although in the beginning some of the cells which are mature increase, at the end they decrease in all lineages. So there's pancytopenia in a way. But anyway, so the chronic myeloid leukemia. So in this case, what really dominates our neutrophils? So typically we'll see mature neutrophils. So also these neutrophils, they function pretty good. Okay, they function pretty good because they're fully mature or very well matured. Okay, so these are increased neutrophils. But what we see also typically that the erythrocytes are pretty normal, like level. So they got a pretty normal level. They could be a bit decreased later. And thrombocytes are typically increased. So platelets are increased a bit. What is the hallmark over here? And watch out, we don't see any lymphadenopathy over here. That's not typical because we're talking about myeloid lineage. But what we see is a really huge spleen. Okay, so typically over here, as there is an increased turnover of the cells, there is an enlarged spleen. And this is like the hugest. So if someone asks you where is the really, really huge spleen, remember it's in CML. It could be a big one in CLL as well, but not as big one as in CML. And CML is the biggest. So, and typically it's so big that it compresses the stomach. So typically when they eat, they feel that they're full immediately. They eat just a bit and they feel that they're full because the spleen is so big over there, okay? So that's a hallmark in a way. And another hallmark, and we mentioned it last time, is that typically you have increased basophils as well. So in a way, if there are increased basophils in the blood smear and neutrophils, this should ring the bell for you that over here we could have a chronic myeloid leukemia, okay? Again, and just to write it down, remember, lymphadenopathy is not typical. So lymphadenopathy is not typical, okay? So the lymph nodes, they look pretty normal. Because there is a huge turnover of cells that have nuclei, in case of CML, there is a risk of hyperuricemia. And with this is dangerous for acute kidney injury, okay? And gout, of course, so gout, okay? There is a huge turnover, not as huge as in leukemias, but anyways, there's hyperuricemia, so what we should be watching out are the kidneys. The cool thing about BCR-ABL, if it's the 922 translocation, and that's in most of the cases, is that we have a treatment for this, and it's a great treatment. It's a drug of the last end of the century, and it's called imatinib. or if it's a brand, it's Gleevec. Okay, and this drug was a total breakthrough because it blocks the tyrosine kinase. So blocks tyrosine kinase. It's the first generation. Now we have more generations, and what happens over here is if you're under this drug, it won't cure you. You have to be continuously on this drug. But when you're under this drug, you will see that the Philadelphia chromosome will disappear, okay, as well, and the cells. So it has a huge impact on the outcome, and it's very important, and it totally changed the prognosis. Typically, CML happens in older people over 50, and of course, the ultimate cure would be transplantation, but it has its high risk of death, especially in older years. This totally changed the prognosis because people can live for many years on imatinib. Okay?
Yeah, and can I ask a question?
Yeah.
Will it be like chronic till it's about 20%? Like chronic myeloid leukemia? And
Yeah.
then it transforms to acute?
Yeah. As I said,
Okay.
2/3, unfortunately, 2/3 of these. It depends, but every year, we could say 20% of these can transform to acute myeloid leukemia. Yeah. But of course, this drug totally decreases the risk. Yeah.
Okay.
Anyways, so that was chronic myeloid leukemia. Okay. Then we have polycythemia vera. And so, thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.